Good morning, everybody. Welcome to our Thursday episode of Humanities Cafe. I'm glad you could join us. My name is Stacy Chadasha. I'm with the South Dakota Humanities Council, and I'll be your host today. We are going to be talking about a topic that I don't think a lot of people are aware of. I know when speaking with our guests here briefly, I was surprised by what I was able to find out, and I live in Brookings, South Dakota. So the issue that we're talking about today, rural and reservation healthcare crisis in South Dakota, is important because I don't think a lot of us have even the slightest idea of how serious it is. I am joined today by two amazing guests, experts in the healthcare field. I'm going to let them introduce themselves to you.
Sure.
DenYelle, you want to go first?
Sure. So my name is DenYelle Kenyon. Thanks so much for having us, Stacy. I lead community health and engagement efforts and work with Damon and Donna Strapo there, and for the medical school at USD, as well as our Master of Public Health program. And prior to that, I led research, my own public health research focused on adolescent health, doing a lot of prevention, intervention, evaluation, working with the tribes, our tribal nations, to build their research infrastructure in the region, as well as training undergraduates. So glad to be here. Glad to have Damon.
Me take tokelak chiwopila chichapalo yuha chante washtena pechuza papalo Damon Leader Charge machiab sichongo ogalala lakota hemie. My relatives, thank you first and foremost for this time. I greet you with a heartfelt handshake. They call me Damon Leader Charge, and I hail from I'm an enrolled citizen of the Rosebud Sioux Tribe. However, my mother scolded me in a really good way about 12, 15 years ago, saying that we get hung up in this paternalistic viewpoint, and she said, no, you don't only come from your father's side, you come from your mother's side as well. So Sichongo is the Rosebud Sioux Tribe, the traditional moniker. Ogallala is the traditional moniker for the Ogallala Sioux Tribe. So I'm glad she did that in terms of helping me develop an introduction accordingly. So I'm really honored to be here. I'm the overall director of tribal outreach for the university, and 50% I'm part of the community health and engagement offices at Sanford School of Medicine. Again, thank you all for this time and the invitation.
And Damon, just so we have a little bit further introduction to you, what was your role prior to what you're doing now?
Sure. I've done my undergrad and graduate coursework at the University of South Dakota. My undergrad was in addiction studies and native studies with a minor in psych. I had some mentorship that told me, like, if I just wanted to do addiction studies or native studies, go ahead and do that. However, I took it a different direction for my master's program, and I built a program in administrative studies and public administration, which I'm still attempting to finish because of some incompletes. However, it enabled me to pivot to doors and opportunities that were opening for me. I went back home in 2011 from USD. I am a second generation Chukwamani Toyati or Coyote Nation. My mother had me there in her undergrad. I keep going back, and now I'm back as not only was a student, but now as staff. And I went home, and I have to tell this part. They tell you to get an education and come home. I've always fielded questions. Do you have to? It's not that I had to, it's because I wanted to. However, that was easier said than done. It felt like a lie. I had to really knock on doors, to pound on doors to get my foot in the door. I thought male leadership would really take me under their wing. They didn't. I don't know if it's intimidation, jealousy, whatever, but I ended up working for some grants that were in suicide prevention. I worked part of a grant that was the effects of exposure to violence, which was the past legacy work of Attorney General Holder under Obama. We were only one of 7 spots in the nation to get it, only one of 2 that were tribal. So it was really great work, getting my foot in the door. And then eventually I did some Indian education work through Gear Up. I don't know if some of you remember that, heard that. There was a big scandal with it, much like a Hollywood script. it taught me a lot of what to do and what not to do. It was all of that scandal was above my head. So I was with Europe prior and after. I have to mention that experience and Indian education at that time. And then eventually I went home, and those knocking on doors and getting my foot in the door really helped, because I had counsel lobby for me to take that position. Obviously I had to apply, interview, and then I got it. It was a 1.5 year position as the health administrator. What is the health administrator? That's your conduit between tribal leadership and Indian Health Service leadership, which is funded through HHS. So that wasn't only at the hospital unit, but it was also regional, which is Aberdeen, which is the Great Plains area for IHS. And then also the conduit between the director there in Rockville, Maryland for IHS. So I love my job. It was a 1.5 years that felt like 3 to 5, because there's no politics like tribal politics, and very high highs, very low lows, underfunded, understaffed, but I loved it. It afforded me a lot, and eventually led me back to University of South Dakota.
Wonderful. Thank you for that introduction. I wanted to get the point across that you have a really in-depth background of tribal health issues.
Sure.
What it's like on the reservation right now, and in the past. It's interesting that I'll start off right away, and I'll put a link to it in the comments. But Damon had shared with me a video from 1973 about the healthcare crisis on Rosebud, and I watched it, and really not much has changed. So today's topic is that we're in the midst of a rural and reservation healthcare crisis in South Dakota. Can you start off by telling us what that means?
Sure. It's been a crisis for generations. However, it must be remembered, like we were talking prior to this, and you covered it a little bit, is like, wow, I didn't know nothing about this or that. And that's the systems of the systems that strategically put barriers in place for us not to know about each other. If we're going to truly create health equity, then it's breaking down those barriers. And some of this information is totally not to make anybody feel guilty, but it's the fact of the matter. From historical trauma to intergenerational trauma that leads to our health disparities, to our social determinants of health. And I have great conversations like this with you all and with med students, whether it's a group or whether it's individually. I have been doing a community identity tour of the Rosebud Sioux Tribe for about 8-9 years, and I finally got called on it in a good way. It's become very popular. I take 5 med students after they test out of one of their blocks, and it's a 12-hour day. We drive out to Rosebud. We get to see 13 of our 20 communities after we pass the Missouri River. And that's per our treaty, Fort Laramie Treaty of 1851. We also have the Fort Laramie Treaty of 1868, which are very foundational. And it's busting down those barriers. It's busting down the stereotypes. We may get free healthcare, but we believe our ancestors, per their treaties in perpetuity, is that we prepaid what was promised to us. If you looked at the map of 1851 to 1868 to reservations now of the state of South Dakota, we gave up millions and millions and millions of acres. If you add in mineral rights, timber rights, water rights, even the valuation of the gold in the Black Hills, I've heard that at 4 trillion, give or take $1 trillion. We should not be in the conditions that we are. So one of the strongest feedbacks that we got was, I think she's an MS3 now, a med student in her 3rd year. It's from Sturgis. She said she learned more in 12 hours with me than she did in her 12-year curriculum here in South Dakota. So that's what it's really about, is learning about each other to gain that understanding. And that video that we premised, and you can share it. Please take a look at it. It's a 20-minute look. I used this for a panel discussion on a healthcare crisis, and we found this in the oral history department at USD. And I had a mixture of emotions, happiness, sad, anger, because it was really beautiful to see our relatives from that era. They looked very healthy. They don't look like our people don't look like that now because of addictions, violence, et cetera, et cetera. But the issues that they're covering in that video are still the same today. So it's not only our leadership, it's the United States government's leadership. And, these are, and like, we were covering the questions before you all joined us. They're very loaded questions for us, because there's a storied history why we didn't just all of a sudden have such health disparities. I've heard throughout my life, get over it, move on. That's easier said than done. I've come to a point of healing and recovery. Next month, I'm 21 years clean and sober. I don't always hide that. I don't always share that. But some of our relatives are just trying to make it day to day, not to justify, but rather the explanation rather than the excuse. They're just trying to make it to their next meal. And, it's that whole conversation is, give them the boots so they can pull up their bootstraps. Some don't have straps. Some do not have boots. So yeah, that's a long-winded answer and just part of it. And what we're covering here could be a semester in any respective institution, whether it's
Sure.
Intro to Native Studies or any of the classes that we have at the School of Health Sciences.
Thank you. And part of it too, David, we referred to what we were discussing before everybody joined us. I was surprised personally when I went to the I think it was Rural Health Information Hub. And when I looked at the map of South Dakota, which we all know we're a rural state. And when I looked at the map of South Dakota and realized that in far northwest South Dakota, there is a severe lack of healthcare facilities. And then when you realize that some of the underlying factors that make up the crisis, like a shortage of physicians and healthcare workers, a lack of facilities, that's one piece of it altogether. DenYelle, can you speak to that piece of it? Like what's going on with the facilities and the lack of healthcare workers?
Yeah, I think even taking a step back, it's like thinking of South Dakota more broadly. We're an overwhelmingly rural and frontier state. So by national definition, all of our counties, but two, so 64 of our counties are considered rural. And like Damon said, like the access and our physician and primary care shortages go a lot toward like access to care, and that only 15 of these counties don't have a shortage of these primary care providers. And like the numbers are saying we have to grow by more than a quarter in the next 6 years. So we really need to like not only grow like the hospitals and the providers, but approach this from that health equity lens, looking at our social determinants of health. And like Damon had mentioned, like this is kind of brought us here from a variety of policies and things that have happened in the past. And our rural and tribal lands have very similar situations. And in our state, the tribal lands have the double whammy of being facing like both of those, the historical piece and being rural. So they've got all of those social determinants like fewer economic opportunities. Our rural areas have higher prices for healthy foods like fruits and vegetables and considered food deserts. They have higher rates of accidental injuries, and those high risky behaviors that Damon mentioned, like smoking and substance use, kind of go along with that. So it really results in, so it's even beyond like access and the types of hospitals, but it's a broader system. And thinking about resulting in like lower life expectancy. So Stacey, earlier you were talking about looking at the maps of access, and that when you look at like our maps, and even considering like all of the counties in the U.S., like the top 5 of the poorest counties in the U.S. are here in South Dakota. And unfortunately, that's like, depending on the health outcome, things like the most basic health outcome, like life expectancy, we like South Dakota overall, is a life expectancy of 76 years old, where in Ogallala, Lakota County, it's 66 years old. Like these are huge, complicated factors that unfortunately, like in our rural and reservation areas, we need to address. So when we're looking at, access to care is one piece and social determinants is the other. So in thinking about, there's a lot of different ways to approach those factors, policy-wise, and improving like the healthcare systems that we live in. So we can talk more about that. And I know you brought up like citizens, like these are tough decisions, right? About as our rural areas are losing populations, the population is aging. It brings up issues about long-term care and what types of hospitals we have open, what types of care is available there. Like OB care is lessening in rural areas, mentioning that there's no emergency hospitals in our rural areas, that when there are emergency services, they're often not 24/7. So these are critical things when you're looking at, distance to care and ability to get people care when they have injuries or a heart attack and things like that.
And now that you mentioned OBGYN, DenYelle, I noticed that there was a recent report that indicated that South Dakota leads the nation in infant mortality rates, and pregnancy-associated deaths are going up. So how is this, or at least in part, attributable to our rural and reservation healthcare crisis? We had talked briefly before everybody joined us. I was shocked to learn that you can no longer have a baby in Sisseton unless you travel to Watertown or Fargo, because they've closed their OBGYN delivery services in Sisseton, and Damon mentioned that too. Where Damon, I'll let you speak to that, and then let's talk about what impact does that have on our infant mortality rates and our pregnancy associated deaths?
Sure, it has a huge impact from a tribal lens and also a contemporary lens. We haven't had an OBGYN suite for years. Leadership has pressed and demanded that be opened. Our consultations, whether they're formal or informal, I've always seen them just take notes, say they're going to follow up on it. We still haven't had that OBGYN suite staffed. So our relatives, if they want to utilize IHS, they have to go to Pine Ridge, which is a 90-mile trek one way. And again, from a tribal lens, we're not having our babies within our tribal homelands. So a lot of protocol is supposed to take place, doesn't take place, whether there's a loss of teachings or again, they're not able to have them there. So from ACA to Medicaid to expansion, we have had tribal members flee IHS because of lack of quality of care. And that meant that they're going either to Horizons Clinic there in Mission, or they're going to Valentine or Winter, which are border towns off the reservation, or, they're going up to Rapid City or Pierre. We do have beams of hope, and USD is trickling students out there for health learning experiences as trainees. We do also are under that model, under that umbrella, in terms of the Mass General Harvard Rural Health Leadership Fellowship, which has been there. I want to say they're starting their 9th academic year. And I think we're still definitely, from my opinion, still surface, making really good gains, but not as fast as we could or should. I mentioned my position and my journey. I was pre-med, but I went way off my path, like I said, and I finally came back, and this is where I ended up. My mother was pre-med. She had me unplanned at USD, so she changed up to social work. She's got an MSW from Denver, and she's got a MA from USD in guidance counseling, and got to BA from our BS or BA from in social work from USD. And because I wasn't planned, she wanted to start working sooner than later. So I literally lived through our med students because I'm like, wow, Mom, we could have did it. We should have did it. Now it's like our next generation. So we've been trying to grow our own since then, 3-4 generations back. However, us as a satellite office of the Indians into Medicine program at the University of North Dakota, which is funded by IHS, and may I mention that it's funded at the same amount since it started over 50 years ago. So if we're meant to grow our own, it's still with the same funding that we're getting. So across the board, and even especially in terms of our healthcare, we're funded at best at 60%. Our education is at 60%. Our law enforcement is at 60%. Our ambulance service, which is tribally managed by the Rosebud Sioux Tribe, is lower than 60%, but now they have third-party collections in place where they're doing a lot better. So there's a lot of ground to gain. Us as a satellite Office of Indians into Medicine, we're not pulling students from this area. We are getting some really great students from Oklahoma, Pacific Northwest, the Dene, aka the Navajo Nation. So, in terms of your specific question with maternal child health, when I was a health administrator, I hate saying this on record, but when I was there, that was a low priority. Our director was mandated to find her own grant to keep her offices going. So if our leadership is campaigning on, oh, the children are sacred, oh, the elders are sacred, sadly, they foul. And I get it. We're reactive because we're only at 60% funded. So our leadership is reacting to whatever's happening. But if we're only intervening and we only have some prevention and no postvention, that logic model is never going to work. So, I helped her the best I could. She did get a grant. I can't remember what it was called. I think she might be in her second to last year. She might be mandated again to find her own grant funding if the tribal council doesn't want to fund her program. And that's
Well, and I think,
detrimental, if our young parents don't have those type of teachings in terms of maternal child health, that baby, that precious, that Wakanja, that sacred being is gonna really start off on the wrong foot.
well, and I think bringing up the IHS funding piece of it is important too, because it's kind of important to note that the facilities are there. But if they're filled to capacity and you can't expand because you have no money, then it's kind of stagnant. And then on top of that, there's increased costs of all kinds of healthcare, provisions, but there's no increased funding. So it's stuck.
Yeah, I want to mention real quick, our past dean of med education, Dr. Beard, who's no longer with us. But once he went out to Rosebud and Pine Ridge, light bulbs start going off. He likened those two units. So we have hospitals. We're hospital status because of our population in terms of those treaties. He likened those to Huron's hospital. So there are big facilities. However, their systems, their hardware, software is antiquated. They're institutionally based, which means you're literally going to be opening and closing windows, register, opening and closing windows to outpatient. It's not literally, but it's still kind of. Whereas you have the Chickasaw Nation and who has compacted, which is tribal self-governance, which means they're basically controlling their destiny in terms of healthcare, immaculate healthcare system. One hallway where every department comes out to you and their creation stories in the world in the floor. Robotics in their pharmacy, it's a drive up like a bank teller. So, there's things that can happen that could make it possible to really get it to where it needs to be. It's just that the Great Plains area is really pulling up. I hate saying this because I'm a proud member of my tribes, is we're really pulling up the back. In terms of the Northwest area that you say is like there's nothing. So you have the Standing Rock Sioux Tribe, and the uniqueness of them is the north part is in North Dakota, the southern part is in South Dakota. They have a clinic. And I don't totally know the story of why they're only at clinic status. Then you have the Cheyenne River Sioux Tribe. And one is at 3.4 million acres, and the other is at 2.8 million acres. So they're very large land bases, which again lends to you why is it so desolate? Why is there not much services? In terms of what Cheyenne River got's going for them, and based in specific to recruitment and retention, is they have a new hospital. I haven't been there yet, but I heard it's very nice. They had a lot of involvement in terms of building and developing that, so they got that going for them. However, the tour that I mentioned, and we have health trainees coming from Harvard, from University of Minnesota. When they come out here We know it from South Dakota that we're rural, but when you get to somewhere like Rosebud and we have three hubs, Mission, Rosebud, and St. Francis, when you get beyond those hubs on my tour, you're gonna realize it's remote. What does that mean? That means you're gonna go to areas where there's no connectivity. If you're expecting a text, a snap, an email, a call, you're not going to get it in some places for 15 to 20 minutes. It's nice to disconnect, but a lot of people are connected to their phones. But it's important for, to understand that lack of access. It's not only a healthcare, it's also a 911 call. Our ambulance service is probably staffed to only fully staff 2 ambulances, when for 1 million acres and that population, we should at least have 4 ambulances ready to rock and roll. We don't. We're lacking EMTs, those that have those special services. So our lack of access is gas. Some communities don't even have a gas station. Healthy foods that you can get hot Cheetos, hot Takis, cases of soda almost at every place. But if you're getting organic, but there are, I have to weave in some resilience in terms of what the fact of the matter is, we are getting back to revitalizing our traditional foods. I'm sure you all can relate to this. We're not very far removed where everybody, if not everybody had a garden, I remember on the res in the community of Parmley, if not every house had a garden, every other house had a garden. Whether they were doing it on their own or there was a program to help them get tilled and to plant their food. So there are things that are coming back, but it's us perpetuating what the systems have strategically done. We have
I think one thing you
recovery
mentioned,
to do.
Damon, that really piqued my interest too is you mentioned the amazing new facility on Cheyenne River. It's a gorgeous facility, but are they staffed? Like, are they having trouble getting the staff?
That's a good question. I'm actually at the Lakota Nation Invitational and I'm in leadership meetings, and this healthcare crisis topic comes up. So I know the chairman, I'll ask, that,
Okay.
and maybe I'll come back with that answer. One thing that's on my mind, and you can fill in a little bit if I leave anything out, DenYelle, but we were working with Deanna Jansen Eastman. She was the director of nursing at Santa Iglesia University. And we were trying to develop a relationship, a partnership there through an articulation agreement. And this always sticks in my head because I would see vacancy rates at IHS when I was the health administrator, but she did an assessment on Todd County, which is the Rosebud Sioux Tribe, Millette County, which is north, White River, Tripp, which is winter, Cherry, which is Valentine in Nebraska over the state border, and Bennett. The vacancy for nurses was 80 plus. Did I get that right, DenYelle? It was at least 80 plus. So we have we already know the national trend for nursing is out the roof, but for us to have 80 nursing positions vacant, it's tough. So we can't recruit, we can't grow fast enough.
Okay, I'm going to open it up to, this is an interactive program and I'm interested in what everybody else has to say. Do you guys have some questions, comments, suggestions? What's on your mind?
I could speak to the maternal care at Cheyenne River. My first pregnancy was there in Eagle Butte, and talking about that and just to the shock of it, like they had to have the doctor singular come in, from Pier for that. And so when I did have my water break, or whatever, and then sitting there waiting and then you were on diversion, they wouldn't deliver you there. So I was sitting there for hours and hours and hours as a first mother, waiting to see where you'd go, and waiting then for that ambulance to take you there eventually to Rapid City to have my child delivered there by the doctor who didn't give me the care, along the way as it was available type thing. But also having those issues of being a first-time mother and then having to wait for that ultrasound, or like you said, travel down to Pine Ridge to have it. And it wasn't until, something had to be tragic, you had to be high risk, something had to be wrong with baby or mama before you were to get those ultrasounds, to have that care. And then at that point, still had to travel to Rapid to have those ultrasounds done if your markers were off. So I can speak to, the maternal care as far as that goes, and the staffing and having to have those doctors that come from outside occasionally to do the care of the whole community. So that is difficult for maternal and definitely an issue.
So Tara, you were in on Cheyenne River, and you ended up going to Pine Ridge?
They
you
said
could
I
have
would
had to go to
have
Pine Ridge?
to go to Pine Ridge in order to get an ultrasound. It wasn't until like your lab work came back, if there were any abnormalities to that they then sent me to Rapid to have my first ultrasound done. So it was all, in the timeliness of your last menses, of when your due date was. But the doctor all along's like, you're either having twins or you're further along. It was all guesswork until you got to that point in your pregnancy where it was, okay, this is when we'll do this lab. And if anything comes back, then it's, oh, your kid's either going to be disabled or you're further along. Like, it was always a guesswork in my first pregnancy, which then lends to anxiety in that pregnancy, or, that can then imprint on your child as well, or, the different things of the unknowns while you're dealing with that and not having that consistent care, when you are dealing with an IHS hospital. So I was grateful for getting care and having a hospital there, but then that also lends to the people who don't have transportation. How are they going to get to Rapid? How are they going to get to Pine Ridge? Like that. Then what? Then you're just a mom there and you don't get any kind of care. That's also scary for that. Luckily I could get to those areas and in the middle of winter as well, for, trying to have some of those of going to do the ultrasounds in the middle of the winter from Eagle Butte to Rapid City. And that trek and those roads aren't always going to lend to being adequate as well. Right. So
in geographical context, because I am not that familiar with South Dakota as a whole, how far is that? Like miles or time wise? What kind of a time are we talking about here?
Rapid City and Eagle Butte.
Yeah.
Yeah, I'd say it's probably 2 hours. I'm guessing now with. So that was, and I'm talking, that's 2012. My oldest is 12 now, but also I can't imagine, it was the new hospital, and I just can't imagine that things have been different. You can have those fancy, like you said, facilities, but then if you don't have the people that have the knowledge, don't have those backgrounds, don't have that drive to be in that medical, field, and are they training the people who live there to be in those settings, other than, to work the EMS possibly, but then the burnout, we don't talk about that in that medical field either. If they are with the EMS, I have a friend that works there, and the things that you see, the traumas that you see when you're working, that on the reservations, just like the burnout and trying to get staffed for that because of it too. So that's not something talked about enough. So.
And I think part of what goes falls by the wayside too in these discussions is, we're talking about physical health care, but this also includes mental health care, which is probably, from what I understand, an even bigger crisis than, medical health care. Does anybody have any additional questions? Thank you for your comment, Tara. That was interesting. Anybody else? Okay, so I have going to take a little bit of an aside here. I'm curious as to whether what
Sorry,
effect,
can
if
you hear
any.
me? Oh, I'm sorry. I was trying to get the microphone to work. Can you hear me?
Yep.
Who's this?
Yeah. So this is Marielle. I'm a resident in neurology at
Okay.
USD in Sanford, and I was just wondering if this hospitals in the reservations have telemedicine set up. Is that like a possibility? Say like yeah, like in
Yeah, they do have telemedicine. I don't think Avera owns that anymore, that department. I did tour it twice as a health administrator. We did have Dr. Toby, who's part, I don't think he's on anymore, but he was on, and he's the director or the person. It's his legacy. I'm glad he's calling it, but it's his legacy work in terms of the Rural Health Leadership Fellowship through Mass General Harvard. So they have a partnership between Rosebud Sioux Tribe and the Rosebud Indian Health Service there. But I know they utilize telemedicine quite a bit. Some of the units in terms of the contract that IHS had with the Vera when they had the telemedicine, I know Rosebud was big in utilizing, and I would say that would be Dr. Toby's efforts. So they are utilizing that, and I've seen on one of our questions, it talks about loan forgiveness. There is loan forgiveness, but I think that's only through IHS's 437 program, and that's for federally recognized students. If they were to get that scholarship, then they would have to pay it back in time at one of our facilities. Residencies, I think that's a definite long-term goal, dream. In the American Indian Health Improvement Act, and back decades ago, I don't know if it was 80s or 70s, there is a couple of sentences in developing a pilot program at USD's med school and utilizing the IHS service units throughout the Great Plains area. Used to be called Aberdeen area, so it says Aberdeen area, and creating residencies. Obviously, no money was appropriated because it never happened, but you know that's been a discussion for decades now, and I think there's a lot of potential there, a long time coming.
Just thank you for that question, Marielle.
Stacy, I've got one for you.
Okay.
Damon, I was really interested in your comments early on when you started with your introduction about lack of leadership. And I'm curious if there are any programs at the very, macro level on the reservations encouraging young folks to get into the science and the medical field to get them started. And as a follow-up to that, I know there's a program called Frontier in Rural Medicine. I wonder if the reservations have access to that.
Through the border towns they do. So we have a site in Winter and we have a site in Mobridge. So the students that are going to those sites always reach out for more information.
Okay.
And this is a good example of what I can give them. I got resources. I'll share them with you, Stacy, so you can pass on to the group. I have an Indian Nations 101 from the National Congress of American Indians website, which and they also have a healthcare specific. They're older, but they're still very relevant. I would say they're like 4 or 5 years old. So those students always want to know more. So it's even the handshake, the softer or the more graceful your handshake, the more respect that you're conveying to a tribal member. So if they come in there and do that right away, it's gonna help with their with the trust issues. And those trust issues aren't with that student doctor, aren't with that provider. It's a storied history in terms of how badly we were treated at some of the IHs. Granted, I'll cite my mother, like and me. I'm glad to have free healthcare. Like I said, our ancestors believe we're prepaid for our healthcare, education, et cetera, in perpetuity per our treaties, but that hasn't been upheld if we're funded only at 60%. But even a handshake, they're only going to get 30 minutes with this patient or so, and then the semi-eye contact, and open-ended questions. What do you do for a living? That's not going to come off very well because there's not many job opportunities. Our relatives are lacking job skills because we have high unemployment rate. We have such high dropout rates. So it's about us becoming innovative and creating some type of programs to really build up our people, and again, to get them to that stage of wanting to heal and recover.
Thank you.
Damon, there's a question in the chat. It says, do you think the Bush Foundation would partner on the USD residency program with IHS facilities?
Good question. I'm sure they would, along with a lot of other organizations. We with Dr. Beard, our Dean of Med Ed, and DenYelle and I being out to Pine Ridge and Rosebud twice, and Dean Ridgway has been out to Rosebud once. We know everybody wants our so we're developing an elective. We kept getting pushed back by the universe. Hindsight's 2020 in terms of technicalities, et cetera, and we'll look back, as we all know, hindsight's 2020, why this ain't really happening yet. And there's a lot of technicalities. IHS is a federal agency, so a lot of red tape. And, you know, just trying to navigate those systems. You got to crawl before you can walk. And as we had said, you know, there's been this pilot program mentioned decades ago, but leadership from across the board, from the tribes to IHS to USD to, and like I'd mentioned, even Mass General Harvard are in the conversations of really, you know, making sure this happens. But, you know, it's taken a while, and I'm sure that has a lot to do with it. We want it to be done right.
Another question in the chat says, can you speak to where there is the most need for pediatric care on South Dakota reservations? And I would expand that to say in rural South Dakota in general.
Yeah, there's a definite need. I mean, when Dr. Beard was at the 2 units, I always point to that, because in his mind, if we're gonna send students out to our hospitals, according to he's got to make sure that they're having the right experiences in terms of double AMC standards. So the fact that we don't have an OB suite and Pine Ridge does, that's already apples to oranges. So there's a survey that has to be done to really, you know, who are they gonna be under? Are they board certified? Things like that. So I know there has been a branch off. Dr. Sundberg, who was a fellow for the Mass General Harvard Rural Health Leadership Fellowship, who is a pediatrician with University of Minnesota, has branched off. He does still come down to Rosebud to do care, but he also does work in Cheyenne River. So there are things happening. Even before us, there was stuff happening between Rosebud, Pine Ridge, and Cheyenne River. There was turnover at those respective hospitals and clinics, turnover on our side. It's just, you know, connecting the dots, and, you know, if we're getting spread thin, is really, you know, ensuring we're able to make this stuff happen.
I guess I want to know too. I mean, you mentioned telemedicine, and I want to know, other than telemedicine, what are some of the things that rural and reservation healthcare providers are doing to mitigate the crisis? So, what other efforts have been beneficial so far? We discussed telemedicine, but is there mobile clinics, community health services, anything like that?
I know the health administrator that took my position, who's still in there now, had through the ARPA Act, had purchased a mobile unit. However, I don't think it's ever been out to the community. No, I take that back. It has been, but not at the level that we'd like it to be. When I was growing up, our community buildings, every community has a community building. There used to be a clinic in most of those community buildings. They're no longer there. But I know one discussion or one issue or barrier that was happening is if they were gonna allow a doctor from IHS hospital to be within that unit and go out to the communities, there was no way to expand the walls to capture that third-party collection when they're out there in the communities. So it was very technical. That's kind of all I remember from that. There was a lot of people working on it, so.
Okay.
Yeah, I'll just add like the partnerships to do like the mobile clinics. I know there's a couple like at the state level, and that the partnering with the different health systems on like the cardiovascular screens, the breast cancer screens. There are pieces, and I think like that early screening is huge, because a lot of the times, especially with cancer in Native communities, the cancer is diagnosed later, like stage 3, that if we can get access to these screenings earlier, these cancers can be treated. So again, looking upstream, if we can invest in a lot of the preventative care, the blood pressure checks, the wellness, is huge. There's a lot of focus on the community health centers and FQHCs and serving our rural communities and getting that prevention care, establishing that trusting relationship that Damon talked about, that you can establish long-term care with a provider so they see when your health is changing, and really address that on the basic level before it comes to a broader scope and a broader problem. So a lot of that needs assessment work needs to take place at that community level to develop the interventions that are most needed.
There is a
So,
question,
go ahead. Sorry, Damon,
comments
go ahead.
in the chat. I'll definitely, I'll put my email for anybody and everybody to reach out. Yeah, I definitely would be interested in having those discussions if I can help and assist in any way in terms of the Smile Network International question that was just posed. The dental need really reminds me of what you brought up in terms of the behavioral health. Now, I'm on record when I was a health administrator, not only where's USD and all of this, but also we need a behavioral health army. So I'm here at Lakota Nation Invitational. Some of you haven't heard of it. It's a big basketball tournament. Tribes have conferences, trainings, retreats. We get it. It's a chance to come up and, shop, end the year out together and watch the basketball games. And when I was a health administrator, I was proxied by my tribal president then to go to a consultation with IHS. And to me, it was formal, but it seemed very elementary. So they had all the leaders stand up and list their top 5 needs. So tribal presidents or their proxy was getting up and writing their top 3 or 5 needs. And I'm like, I know this is just gonna be filed away and probably nothing's gonna be done with it. So behavioral health was 1 and 2 for every tribe. I would guarantee that it's still 1 or 2 for every tribe now. One thing that our regional director at that time, who was an enrolled member of the Rosebud Sioux Tribe, but no longer is in this area, he was on the record quite a bit saying he was working on a 52 cent per dollar budget, which means he's funded at 52% here in the Great Plains region. Great Plains region is North Dakota, South Dakota, Nebraska, and Iowa. And in that meeting, he had said no, I better not say this part, because he said the part I'm trying to, he didn't know why Pine Ridge was getting more funding in terms of their behavioral health offices than Rosebud. So they're staffed at 34, Rosebud is staffed at 9 to 11. So even though our enrollment is only 10,000, so Pine Ridge, Oglala Sioux Tribe's enrollment's about 55,000. At the most, 2/3 reside there within their tribal homelands, aka the reservations. The others live nationwide. Rosebud is 46,000. Same thing, at the most, 2/3 residing within the tribal homelands, the rest living nationwide. So he didn't know why there was such a disparity. So we're always told about these formulas, our shares. Those formulas and shares are never shared with us. There's always a claim that they're going to share them with us. And then I get it too. The census, we're undercounted in terms of our census, and I know those numbers are plugged into this to the quote unquote formulas. But again, when that's never shared with us, how many shares we get per our region that comes down from the headquarters. So I worked with the CEO. I don't know where he's at. We work really well together. Our leadership tried to pit us against each other once, and I was like, no, I'm not playing this. I actually work really well with this guy. When I first took the position, I was like, it seems like we're in here to fight or argue. And I was like, how do we navigate to yes? How do we navigate to a solution? Everybody just went back, and there was no more arguing and butting heads. I was like, we're just here to try to find a solution. So that guy I worked really well with. I wish I could have got him on record. I joked with him. I'm like, yeah, I'm gonna cite you, but he even said it himself. You know, our PRC, our purchase and referred care, which used to be contract health, and that's how our patients are covered when they're flown out to Rapid City, whether it's Avera, Sanford, or Monument. That's how they cover our patients. However, it's a crapshoot. We're priority one, which means if you get flown out, you're only probably going to get paid. Your bill's only going to get paid if it's life or limb. If you get flown out for a broken leg, you could end up with a $50,000 bill. So for an 18-year-old to an 88-year-old, that's very detrimental to your credit. So, you know, I've heard these officials say, you know, different things on the record, off the record. It's a defunct system. It's inefficient. They know it. Yeah, it's layered. It's a federal agency.
So really quick, we're down to about 10 minutes. So I want you, DenYelle and Damon, if you could tell us what we can do. What is everyday South Dakotans could do to further this issue to help make a change?
You want to start, or should I? I can start
Sure.
from a bigger
No,
perspective.
I think I would, and I've kind of said it throughout, is, you know, gain that awareness and education. I have resources that, you know, I just put my email in a chat, or I'll send it to Stacy and she'll get it to the overall group. It's just gaining an understanding. You know, we're not just poor drunk Indians. You know, that's what the cover of the book says. But if you delve into that book, do your research or become an investigator, there's a reason why we're dealing with such disparities. There's generations that don't know that they need to recover. And that's not an excuse, it's the explanation. You know, the boarding school era was 72 years. I helped develop a curricula with the Mass General Harvard group. And on one of these calls, they said, what are the two reasons why you have such disparities, et cetera, et cetera. I'm gonna need about a week to really think and pray on it. And to me, it was the decimation of a way of life through the extermination of the bison.
Yep.
Now that's very trendy. We already knew it. You know, roots and medicines like that. We already knew all of that. You know, keto diets, prebiotic, probiotic. We already had that. It's, you know, so to me, the historical trauma started with the decimation of a way of life through the extermination of the bison, and then the boarding school era, 72-year era that affected our future generation and is still sadly alive. It was an attempt at cultural genocide. You know, me saying my introduction in my language was not supposed to happen. So that's what I, you know, do the research, become an investigator, to gain that awareness.
DenYelle?
Yeah, I would just take like that broader public health lens and like implore people to really advocate for investment in like our public health infrastructure and take a bigger lens, like our South Dakota Public Health Association is doing that, and to find a group that you align with. So like the South Dakota Medical Association is really focused on physician burnout as a way to address like this rural healthcare crisis. Again, we haven't, like in the past, paid a lot of attention to environmental health. And in South Dakota, we've really benefited from positive air quality, water quality, those types of things. But we're learning more and more about things like how plastics in the water can cause cancer. Plastics are in everything. And so not kind of like cutting off like that long-term planning and investment for short wins, and really when we look at like how everyday people can get involved, it's just kind of paying attention. It's really hard, and legislative session goes really fast, but paying attention to like the implications of our policies. So just staying engaged and trying to stay up with what's happening in the news, and picking a topic that you really like, whatever that is, of maternal child health or environmental health, and just getting engaged to learn more and do something.
I did put in the chat, just for everyone's edification, some links that I came across when I was researching for this discussion. There's organizations that we can back. We need to learn more about telemedicine and access to non-emergency medical transportation services. And then, like DenYelle was just saying, Dr. Kenyon was just saying, contact your representatives, pay attention to what's going on. This has been such an eye-opening topic for me, and I hope it has been for you as well. So is there any final questions, comments, concerns, suggestions? What's everybody got to say? Dr. Kenyon, Damon, do you guys have any final thoughts, comments?
All I have is thank you for the time. I hope it planted a really good seed. And again, it's not to make anybody feel guilty. We've had many students that now are like relatives to me that, you know, Andrew Nerlin, Callie Wong, med students that have come through USD, and is like, I need to know about my tribal relatives. And that really helps me in our work and my work. And, you know, again, we don't have a bridge between us for a reason. Both sides perpetuate that, but getting to learn about each other and really understand definitely helps.
Agreed. And I think too, my one comment I would throw in here is that, you know, for those of us who don't live necessarily in a very rural area, there's a good chance you're going to travel through a rural area if you're going to anywhere in South Dakota. And if you or anyone you care about is traveling or visiting or touring anywhere, you might need that health care. You know, you just never know. And this isn't just an issue that impacts rural areas, but like Dr. Kenyon said, 64 out of 66 counties in this state are considered rural. It does impact all of us. So it's an important topic. I think we can all do our part to help. Any final thoughts, Dr. Kenyon?
So just thanks again to everybody being here. Good to see so many colleagues and our public health alumni, Sam, doing the good work of trying to improve public health and access. So thanks to all of you for your engagement and interest in this work. Keep on.
And I think we all echo that for all the healthcare workers here, everybody who's here. Thank you for being a part of this program. Thank you for your participation and your concern. I do want to throw a couple of little announcements out there from SDHC. Next week, I hope, or not next week, excuse me, in 2 weeks, because we're a bi-weekly program, we're going to talk about another important issue in South Dakota. And January is Human Trafficking Awareness Month. And I don't think it comes as a surprise to anyone on here in this program that the missing, murdered and missing Indigenous persons is a huge, huge crisis in our communities all across the state. So we are going to have a couple of amazing guests again. Tanya Grassel-Kreitlau, who is the coordinator for the statewide network against women against violence against women. Excuse me, stumbled over myself there. And Lily Mendoza, who is a 2024 Bush Fellow, the founder of the Red Ribbon Skirt Society, and very active in the fight against MMIP. They'll be joining us to talk about federal legislation that's out there, but what's being done with that legislation to ease this crisis. And then one more announcement, and this is a big one. We are developing here at South Dakota Humanities Council a sister program to Humanities Cafe called Knowledge Keepers. It's brand new. It's something we haven't done before, and it's basically going to be the same time every other Thursday, so opposite Thursdays of Humanities Cafe. And it's going to be solely focused on sharing the traditions, the knowledge, the lifeways of the Oceti-Sakowin. It's going to be an Indigenous focused program. There's so much knowledge out there that Indigenous peoples have been here for thousands of years, and there's a lot of knowledge that we're not aware of. So that's going to be the focus of the program, and I hope that you guys will be able to join us on those opposite days of Humanities Cafe. I did put a link in the chat to the new page on our website. And if you have any questions, of course, you can reach out to me. here at the Humanities Council. In the meantime, we're right up at that 1 o'clock deadline here. So I want to thank our guests today. I want to thank everybody who joined in the discussion. Thank you for the questions, the comments, the viewpoints, and I'm going to bid you good day. So everybody have a wonderful, wonderful holiday season. Drive safe, stay warm. Thanks for joining us. Bye-bye.
Thank you.